Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Health Conversations That Matter. A Women's Journey always strives to improve your well-being through health education. Tonight's discussion is very timely because November is Pancreatic Cancer Awareness Month. According to the American Cancer Society, an estimated 64,000 people will be diagnosed with pancreatic cancer in the United States in 2023, almost a split down the middle between women and men. Pancreatic cancer has rapidly increased over the past several decades, and it ranks as the fourth leading cause of cancer deaths in the United States. Survival rates have increased during the past decade and now approach 11%. Tonight, we are pleased to be focused on improving survival of pancreatic cancer through early detection. We are joined by cancer pathologist and gastroenterologist Michael Goggins, director of the Pancreatic Cancer Early Detection Laboratory, whose research interests include developing tests to improve the early detection in pancreatic cancer and their outcomes. So please use the Q&A on your screen to ask your questions to Dr. Goggins, who will respond during the last 20 minutes of our conversation. Our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance, and you can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. Michael Goggins. Welcome.
Thank you, Kelly. Pleasure to be here to be part of this wonderful series for the public on health conversations. Our topic is, as Kelly mentioned, is improving survival of pancreatic cancer, early detection and prevention. The outline briefly is some pancreas basics, a little bit about some context around cancer screening tests and applying it to the general population versus high-risk individuals. And so who are the candidates that we currently consider appropriate for pancreatic surveillance? What are our outcomes when we have people engage in pancreas surveillance, and a little bit about future directions. So a big question, of course, is why is pancreatic cancer survival so poor? And that brings us to a little bit about the pancreas anatomy. What you're seeing is on the left and right, the context where the pancreas is. It's in the abdomen, surrounded by the stomach and the duodenum, near the bile duct and the liver. And, you know, on the right, you're seeing a little high up, there's a little arrow showing one of its functions is to produce the secretions, the pancreatic enzymes that help you digest your food. This anatomy is also the reasons for the symptoms and maybe why the symptoms occur late. If for any budding histologists, this is what the pancreas looks like. It's basically largely a solid organ that you have the two main cell types there. The light pink little circles are where you make your insulin and other hormones. And these other cells in here in the purple are where the enzymes are made and they get secreted out the main ducts. And if you were wanting to see it on a scan, what you're seeing across the middle here is just a slice across the abdomen. Here you have your pancreas here. There's a main duct running through it where the secretions would come out. You have your liver nearby, some vessels in here. This is where there's some contrast. So it's in the middle of the organ. You know, it's near the stomach in front of it. Spread occurs in these vital areas where there are vessels fairly readily. It's a fairly thin organ, and that creates some of the challenges for early detection. So some of the symptoms, many of the symptoms, in fact, that can occur because of the local anatomy. Some of it has to do with the effects on the gland's functions, the pancreas function. So you get abdominal pain, usually in the middle of the abdomen, sometimes in the middle of the back, where the pancreas can cancer can go posteriorly. You can lose weight because you're not digesting food or not feeling like eating. Maybe there's some blockage to the local stomach and duodenum. And so I know these other symptoms, loss of appetite, jaundice, because you block the bile duct, the weight loss and lack of energy and other systemic effects, weakness and fatigue. If you interrupt the sugar metabolism, with the insulin production, you can get diabetes. Other symptoms, fever and chills. Maybe you're blocking your bile duct and causing trouble there. And other things, blood clots, depression, diarrhea. I'm running through those all very quickly. It's not, of course, they're very important, but in fact, a lot of the times when we have these symptoms, they're often late. Not always. We're of course need to be vigilant about symptoms that can be occurring from pancreatic cancer, but they often are occurring when the cancer is already not at its earliest stage. And of course, a lot of times, some of these symptoms, I have jaundice or, there's something more specific, but often they're relatively non-specific. A lot of reasons why people can have some upper GI discomfort, pain, or nausea or fatigue. So that poses challenges. Obviously, you can visit your doctor to try and tease out what's relevant, and you can get tests on if you have symptoms. The context of doing early detection work is largely focused on, following up certain groups of people who we consider high enough risk, and scanning them, et cetera, looking for signs of trouble long before there's any symptoms. So, and again, the progression here of pancreatic cancer is meant to show you can have a small tumor that's localized, and we can call that a T1. And that we'll see is survival can be very good. This is the local anatomy, the main duodenum and the vessels around. And that'll spread. It can invade the local organs, invade to the lymph nodes here, which also affects the ability to have cure, and of course spread to other organs like the liver. And a lot of times when people are presenting, they're presenting when the cancer is already spread to local lymph nodes or often to other organs. And that does limit our ability to achieve long-term survival. Sometimes the gland will atrophy because you're blocking the main duct, and you literally get a smaller gland, and it's affecting the digestive enzymes or the insulin production. And of course, the concern everyone is aware of is that most people with pancreatic cancer that's advanced stage will not be cured with chemotherapy or other therapy. But having said that, occasionally they are. So even though we're very much after early detection, you do see these examples where you can have a dramatic survival benefit. This is an example of a CT scan, and that's the liver and the stomach there. And this here is showing what are fairly large liver mets, as we call the cancers, already spread there. So normally that would not lead to cure. But this patient who had a BRCA2 inherited BRCA2 mutation was sensitive to this chemotherapy that we had started a trial over 10 years ago, and within weeks there was a dramatic improvement, and he ended up living over 4 years and dying of unrelated causes. So that does occasionally happen, and the earlier the cancer is detected, the more likely chemo is going to work. Although it doesn't often have these dramatic effects. And of course, people are interested in is there a way to improve immunotherapy, et cetera. And this talk is not really about therapy responses. It's really more about screening and early detection. And can you cure it if it's early enough? And as was mentioned, it's not the commonest cancer, although we're seeing an uptick in incidence in men and women. You're seeing it's ranking down here near the bottom of the top 10 kind of thing in terms of incidence. But the survival is a poor 4%. Ranked fourth, 11% 5-year survival, which is an improvement in survival. So how do we deal with this challenge of incidence is quite low. At the moment, the average incidence in the population in the US is about 1 in 57. It has been creeping up a little bit. And that seems also, to some that might seem like a lot. There are a lot of other common cancers that we have to be concerned about. And of course, other diseases, cardiovascular disease and strokes and things that can cause concern. But even then, you see, this risk is spread out over many decades. And so it's not as though at any one point in time, I'm walking around with a 1 in 50 chance. Your chance is much lower, and that ability to identify that someone with at risk of pancreatic cancer is also affected by this. And I'll try and tease this out a little bit. For example, one of the goals of early detection would be to develop, from a scientific and medical point of view, as well, could we have a simple blood test which would help us diagnose the cancer? And the performance of the blood test would depend on having a test that could where the results would be only high in the cancer patients, let's say, and all the normal patients, of course, without cancer, many more of them, they would have their own range, but they would never overlap. You never have a blood test where the normal people would behave like the cancer people, and it just doesn't work like that. More often than not, you're dealing with the healthy people. Some people who are healthy will have the blood test in the range of the cancer levels. And so you're stuck then dealing with the interpretation of that blood test, and you run the risk then, we can call that specificity, who doesn't have cancer, sensitivity, who does. What's the right cutoff for the test? If we put the cutoff here, we'll get all the cancer patients, but the test will indicate, well, there's a lot of healthy people that actually have an abnormal test, and you have to go and chase down what that is, and that creates worry. And that those numbers matter a lot. So if it's a rare cancer, it's a lot more to deal with than if it's a relatively common cancer. Women will get mammograms and other breast cancer screening tests all the time, and they have to deal with a lot of false positives. But it's a relatively common cancer, and so in following up on it, it could be better. But it's there are challenges when you have to follow up on a blood test if you're not sure what the significance of it is. And this plays out if you do a scenario where you have only one person in 5,000 having a cancer. You're going to have 500 people out of 5,000 with a false positive result in this example. And then on the other hand, if you have it where you keep it only very few people in the population are given a test, you use a cutoff where very few people who are healthy have a false positive, you're not going to get all the cancer diagnosed. And so this is part of the challenge. How common the cancer is in the population imposes challenges on how we can apply a test to the population. And because ideally we'd love to screen all people at a certain age with a simple test and be able to do a better job of detecting pancreatic cancer. But the numbers don't make it easy. And we don't want to be doing harm, if you like, to healthy people. And so it brings up, well, is there any role for blood tests for pancreas screening? One of the great tests of interest these days has been the circulating tumor DNA test. The idea that DNA shed from a cancer will be detected in the blood, and that's certainly true to a certain extent for many cancers, and there are multi-cancer detection tests trying to deal with that, and that they have great potential. They're also used for people who have cancer to try and help manage understanding how they're responding. The Hopkins group has done wonderful studies in this area. For example, this is a study where a multi-cancer detection test was applied to 10,000 women, published a few years ago in Science. And what it showed is, these cancers detected by the blood test on the left and the other cancers overall detected, and how many cancers in different organs that were detected. And a lot of, in general, in asymptomatic individuals, again, reflecting the fact that pancreas isn't that common. None of the women had pancreatic cancer. And so that this was a wonderful sort of first glimpse at applying kind of tests like this to the population. But what we've also shown in studies that we've done and others, that when you're applying it to look for the early stage pancreatic cancer where it's most curable, the test is usually negative. So that's the 30% of people with stage 1 pancreatic cancer where you're mostly going to be correctly figuring out who doesn't have cancer. So we need to be able to do better than that for a test for early detection of pancreatic cancer. It's a little better for other cancers. And as we'll see, the stage 1 aspect is quite important. So how do we do pancreatic surveillance now? Well, we have been doing this for a while at Hopkins. We started what we call the CAPS study, Cancer of the Pancreas Screening, in the late 90s. Around the time I started my lab, my fellow gastroenterologist, Dr. Canto, started a CAPS program, and we soon began working together. These are all basically the same study. The last decade or so, it's been a multi-center study that we lead, which is called CAPS 5. All to say is we've been doing this for a long time, following a lot of people who we call high-risk individuals, or HRI here. And these are people who have a significant cancer risk based on having inherited certain cancer gene mutations or variants listed there. These are the BRCA genes and some of the other genes and some rarer syndromes as well. And also, people who have certain family histories, generally they need more than one first-degree relative with pancreatic cancer. In other words, like a person who's a sibling, parent, and then 2 of those, or one connected to another by 1 degree. So a parent and a grandparent. In other words, a first-degree and a second-degree relative. And we do that based on the likelihood of a person getting pancreatic cancer with those kinds of family history, and meeting the age criteria, which is mainly middle age. And then the surveillance we'll come to is imaging. And again, our experience has been gathered over many years. We've held consortia at Hopkins and in Baltimore, 2 of these, to try and bring the international community together. And so this field has slowly progressed. And so, to start from a kind of investigational consideration in the clinic to something that we recommend for people who meet the criteria. And this is an example of a pedigree where you would have a family member, family members where pancreatic cancer has occurred. In this case, these 2 men, and so you have other affected individuals, relative or unaffected relatives, who would be eligible based on being a first-degree relative. People who are siblings. For example, in this example, this young person would be too young. That gives you some idea. But if it was just one affected member in this family, in the absence of any genetic abnormality identified, we wouldn't recommend surveillance at this time, at least. Maybe if we had a better test. And this gives you this set of figures gives you some idea of what the family history of pancreatic cancer gives you in terms of a lifetime risk. If you're looking at the bottom, you're seeing here these low curves, and basically these are kind of the same curves. One is if there's a family member with young onset pancreatic cancer, so these curves are higher. This bottom curve is sort of the baseline if you don't have a first-degree relative with pancreatic cancer. But as if you have pancreatic cancer in a first or second-degree relative, the incidence is high, especially if you have more than one. Right, you're seeing this incidence go up to 0.2, for example, here, 20% lifetime if you have 3 first-degree relatives with pancreatic cancer. And this risk is very low, in your 40s, starts to go up a little bit in your 50s, and you see the curve taking off. And so this reflects what our practice is to try and identify people who are at these ages of 50 or so, and to take a good family history and understand if the risk is sufficient. And so we're not enrolling people who have one relative with pancreatic cancer, but we would if they had, if you like, more than one. The other thing we do is to try and clarify this risk in family members is if you have had a relative with pancreatic cancer, a close blood relative, you could consider having a blood test or a saliva test for, a genetic susceptibility, which you can get in the U.S. fairly inexpensively, a panel of genes. And this is just indicating that this is something based on work we did some years ago, that, when you take people who have pancreatic cancer, they don't have to look like they have a cancer syndrome in their family where there's lots of cancer or there's lots of pancreatic cancer to realize that maybe it is inherited. Most of the time, we don't see a clear evidence that it is, but maybe 5 to 10% of people with pancreatic cancer have a fairly significant genetic reason that we can identify, and therefore other family members might benefit from having that test done. And that would sort of clarify their risk and sometimes determine whether they should get surveillance or not. Again, similar, different guidelines showing that evidence that we support that. And even in people who come to us, the ones that have mutations that they've inherited tend to be at a little bit higher risk lifetime compared to those who don't. This is work we did some years ago. So we start screening around age 50 for family history criteria a little earlier if you're a mutation carrier. And that surveillance takes place over a long period of time. And and that, again, is why we have to, I think, for the moment, limit it because we're recommending scans that are, typically annually. What about these other risk factors? We mentioned family history and genetics and age. Of course, smoking is important. Smokers have a higher risk, that gets to close to a family history risk if you're a significant smoker. But some of these other factors are relatively modest. People with diabetes in general, people with obesity, certain racial factors have a modest, if you like, association with having an increased incidence, not terribly significant. All that's to say, and heavy alcohol, rarely people with chronic pancreatitis where there's a lot of injury, we will survey those. But most of these we don't yet have a simple way of quantifying that. Oh, well, therefore you should automatically get screened, because again, this lifetime risk question, if it's still relatively low, even if you're a smoker, we haven't yet reached the point where we're routinely recommending that, even though these are factors that do influence risk to a modest extent. Obviously, there's other reasons to have a healthy diet and lifestyle and avoiding smoking, which needless to say. Let's see. Looks like we are stalled a little bit. Okay, excuse me. Okay. So in our thinking about this, we're thinking about people whose lifetime risk is around 5% or higher of developing pancreatic cancer. And, we're trying to sort of do as much good without doing unnecessary harm. We don't like to be telling people to get annual scans if the likelihood of needing them is relatively low. And that may change as we make progress with other kinds of early detection tests. So what has our experience been? This was a publication we reported on last year. It was a multi-center study. Our Hopkins team, myself and Dr. Canto and others, and some of the other institutions involved in the CAPS program here in the U.S. And they're listed here. We follow several thousand people. And other people with pancreatic problems are part of the study as well. But it's high-risk individuals who have these family history and inherited mutation criteria. And so, and then going back to what we find, thankfully, we find very few people with pancreatic cancer, even in these, fairly significantly enriched families. They're all in the various degrees of surveillance over, some many years, others only a few years. And we've identified a few dozen pancreatic cancers in that time in this cohort. And at the time of this publication, which we presented, based on a period of funding to provide an update. We had 1,500 or so people developing, being surveyed for a relatively short period of time. And, how many cancers do we get? So when we look at this, what do we find? So here you have two scans. One is an endoscopic exam, endoscopic ultrasound, a little hard to make out, but you're seeing the pancreas here, and this irregular abnormality here. And this is a early pancreatic cancer. And the same here, this is an MRI scan. You see the other organs, and you're seeing this little small area. It's just a centimeter in size, and thankfully localized, and patient did very well afterwards to stage 1 pancreatic cancer. And so people are generally getting annual scans who are in the program. Often they're alternating both tests. The MRI scans and the endoscopic ultrasound scans are generally equivalent. They're superior to a CT scan based on the radiation primarily, but perhaps for some other reasons as well. What has been the experience in terms of the people who get pancreatic cancer? Well, the middle curve here is the main one. These are the people who develop pancreatic cancer despite having regular surveillance, and they have had an average survival of approximately 10 years. And so, and some of the people are still going, that we haven't, they haven't been diagnosed that long yet, but the majority of them have had stage 1 pancreatic cancer. That's shown here. And we have another curve down here where the people who dropped off surveillance and presented with symptoms, and basically they kind of then generally fit the life expectancy of people who never had surveillance, where many of them are presenting with advanced stage disease. So most of them had stage 4. This one had stage 1, kind of fortunate. He had came back for surveillance about almost a year and a quarter or so, and so we put him in the dropped off surveillance category. But he had that might have been a bit unfair. So the stage 1 people basically, in other words, do very, very well. 10 years is a long time to live with pancreatic cancer. Not everyone survives, but a lot of them will survive long term. This person up here had one person died of unrelated reasons, who had this curve here, which are people who didn't have cancer, but who had a kind of very concerning HGD, meaning a high-grade dysplasia, kind of like a cancer in situ not yet invading, which we do look for as well. So, many of these people did very, very well thanks to having been undergoing their scans on an annual basis. And it just shows you what is possible with pancreatic cancer. Long-term survival is absolutely possible if it's detected early enough. An example here, this gentleman, from Maine, he's actually a retired doctor, and he allows this photo, but he's 10 years since his diagnosis, and had his scans done. He'd come down to Hopkins for his scans, and he had his operation with us. So, doing very well. Now, if you take all the people in a group of people who are being surveyed in the CAPS group, who meet that family history and genetic criteria, roughly 1 in 200 per year of surveillance will get pancreatic cancer. So it's still a relatively small number, and that is also why generating this data takes a while, because it's limited to people who meet these criteria. So it's only a smaller fraction of the total number of people who end up getting pancreatic cancer. But at least we have this kind of data to work on, and we're continuing to try and do a better job of estimating risk. One additional study that we we published a few years ago, that should be 2020, what is the role of insurance and basically access to care. So this is a little bit different now to the high-risk individuals. This is just looking at the general population in the United States and how likely are you to have a stage 1 pancreatic cancer? Well, a lot of it is luck, because sometimes people can, have symptoms for a week, get evaluated quickly, and they still have advanced disease. And many people are aware of that. But some people will have symptoms that will drag, and they're subtle, and they want to get seen, by a doctor, maybe get a scan, etc. And what does this show? So this is showing that if you have optimal insurance in the U.S., which is not always optimal, but Medicare, sometimes Medicaid, the optimal insurance, you were, likely, this was the reference, much more likely to be diagnosed with a stage 1 cancer than if you didn't. If you didn't, you were more likely to have these advanced stage cancers by a very significant amount. So this access to care is relevant. Having optimal insurance is relevant for early detection of pancreatic cancer when you're talking about developing symptoms, just in the general population. And if we look at what the data is in the U.S., is maybe these people who do well, maybe they're just all these people are getting screened and they're different. No, in the general population as well, if you have stage 1 pancreatic cancer diagnosed, and staged according to having an operation and the pathologist looking at the results, you have a long-term survival that's really excellent. Here we're showing 5-year survival around 80% for people with stage 1 pancreatic cancer, which is like, what? That's not what we understand, right? Whereas here you're seeing the people who have the other stage pancreatic cancer, and this was the year of diagnosis. This work we published again some years ago, and the survival has improved a little bit. But again, it's this need to get the cancer early where you can have a very dramatic difference in outcome. And so this is work we are, continuing to try to do more for, but there is a lot of hope that we can make improvements. And as therapy gets better, if somebody has a earlier stage cancer, they can respond better to treatment. They're healthier still. And one of the issues is not only having the scan, but having the right kind of scan when it comes down to it. There are different kinds of CT scans. One is a pancreatic protocol scan. It's sort of a dedicated scan of the pancreas, even though it's within the abdomen. You get a scan of related organs as well. Similarly, the endoscopic images are kind of quality images. They're very user dependent, so it takes skill to do these tests well, especially the endoscopic ultrasound. MRI scans are not all the same. The magnets differ, and the radiologic interpretation differs. And of course, there's a great interest in artificial intelligence and being able to, do better with that. But still, the actual scan matters a lot. So it's something to be aware of. Yes, these artificial intelligence is doing cool things. Here you're seeing examples where this is work from our Hopkins team identifying the pancreas in having trained the AI to identify it compared to other organs and identifying tumor and normal duct and things. We're making progress, and the hope is that sometimes these scans where you get hundreds and hundreds of images, and you're coming in for a different reason, and the radiologist maybe they'll miss something very subtle that eventually the AI, probably in not too distant future, will be applied to these scans to help with the routine diagnosis. Here's another example, such cool things. This is, just picked out from the computer from the scan data. My colleague, Elliot Fishman, a wonderful radiologist. So anyway, what about doing improvements in early detection? Can you make improvements? One of the things we've been doing is trying to personalize blood tests for pancreatic cancer early detection. Some people who've had to deal with pancreatic cancer may know the blood test CA19-9, which has been around a while, and has some value in following people with pancreatic cancer as a tumor marker. And so we have worked on a tumor marker gene test to try and improve how we can use CA19-9, and that may help us with early detection. And the basic idea is that it's not a one-size-fits-all test. Basically, we can personalize it by doing a one-time gene test, which helps us figure out, well, how much CA19-9 are you generally going to make based on what your body, what your genes can produce normally, and that would then give us a better idea of when your test is abnormal. And what that is shown is here. If you just take the typical blood test, this is what if you take a group of people, you take 100 people, this is what their levels are going to look like. But when you break them down into different groups, functional groups based on their gene tests, you see the levels are very different. And so all these people, for example, the cutoff is normally, kind of around here, because most of the people are in this area. And so a lot of these people then get false positive results. So this is the kind of approach we're trying to take to improve upon our scans. We're not suggesting at the moment that we're going to get to a blood test only place. We need more work to do that. But having a blood test in between scans is something we're working towards. At the moment, we're doing studies where we're matching up the blood testing and the gene test for the tumor marker at the time of your scan. So trying to improve upon performance of the blood tests is something that we're very excited about, is because the beauty of it is that it doesn't cost $1,000 a shot, and you're just taking available blood tests, and you do a one-time gene test that we have at Hopkins, and that then allows you to have that test perform much better than it would otherwise. So what about prevention? Really, this is mostly a talk about early detection, but we could say a few words about prevention. I alluded to some of them before. We do see precancers that sometimes merit intervention when we're doing these imaging scans. And here's an example of a big pancreatic cyst here in the middle of the abdomen, compressing the stomach. Most of the time, these cysts are not that big. This is what a normal, again, the normal looks like, again, highlighted here where the pancreas is. So this big darn thing here is causing trouble. Thankfully, this wasn't a bad cyst, but sometimes we, in terms of cancer, but sometimes we see these cysts and we're worried they're going to progress to cancer. So that is an opportunity to intervene. The only trouble there is that actually these cysts are very, very common in the population. As you get older, upwards of 10+% when you're reaching your 70s. And most of these are fairly small and relatively trivial in terms of their likelihood of progressing. They do create some concern. And a certain percentage of them will begin to cause trouble or look worrisome, and we can manage them with an operation. So there is and sometimes prevent cancer, although most of the time people with these don't progress. So that's a way of, if you like, doing a prevention. Another microscope picture, again, on the top here, you have the pancreas, what it looks like normally, but down here in the middle, you have this abnormal growth in here. This is just microscopic, but it's blocking all the normal secretions. And so all of this normal pancreas is gone, and that's replaced by fat and scar and things. This is the kind of thing that happens quietly in the pancreas as you get older, and some of the people who have their family histories, et cetera. And so, can we do better at detecting these? Because we can't really see at the microscope level when we're doing a scan. And that's something we're working on. We call these pan-in. Sometimes we'll see these actually on a scan, but most of the time we won't. That's what these images are showing here. More of the challenge is to try and figure out better ways of quantifying these. This slide shows what we can do now with pathology as well. We can apply AI to pathology slides and make this this is what the pancreas looks like. Here there's a lot of fat here in the center of the gland. Surrounded there's a lot of loss of the normal profile. And that may, reflect a certain risk of progression, but we can quantify all these different organs or cell types within the organ. And that's leading us to giving us a better idea to then link that to their images, like their MRIs and like their ultrasound, even quantifying the fat level. So trying to get better at imaging the pancreas to figure out risk of progression is something that we're working on. And, we'll take some time to make it into the clinic, but the imaging will hopefully improve and help us manage people's risk better. Finally, of course, prevention also means doing some of the things that are very important for general health. We don't really have much in the way of prevention to offer. Obviously you should stop smoking, a lot of importance around metabolism and improving your weight. We're interested in we're seeing studies where, what if you just applied the artificial intelligence to your medical record? Could you have some signal there? These are areas of interest. We've carried out a vaccine trial where we just as a pilot, but there's a long way to go before that's routine. Can we prevent cancer with a vaccine in the pancreas? This is something that we're working on. Similarly, we were doing studies on your microbiome, and there's a lot you could say about your diet and optimizing your health for cardiovascular purposes and other purposes. We don't really have great prevention tools other than what I've outlined. So in summary, pancreatic surveillance can detect pancreatic cancer at an early stage. And when it's detected early, long-term survival is actually likely, especially if it's stage 1. Surveillance is only suitable at the moment for people who meet certain family criteria or genetic criteria. And we're doing a lot of research to try and improve this risk assessment and improve our early detection efforts, and to develop get better cancer prevention strategies. So with that, thank you very much for your attention. This is a figure of our multi-center international CAPS group when we had our last consensus meeting at Hopkins some years ago. A lot of great people in this field trying to improve pancreatic cancer outcomes. So thank you very much for your attention.
Thank you, Dr. Goggins. Wonderful information. We've got quite a few questions. So how about we just jump right in?
Yeah.
That's it. Okay. So our first one is from Russ. So when should you seek a CT scan for a definitive diagnosis if you already have symptoms?
Yeah, I mean, that's a good question because it can be a very valuable diagnostic tool, a CT scan. You're talking it over with your doctor. I think if you have a concern specifically about pancreatic cancer, it should be mentioned. A CT scan is a wonderful test that provides a tremendous amount of information. And so, there isn't an easy answer. Certainly warning symptoms, people who have unexplained symptoms. Obviously, if you have things like jaundice, there's an issue about new onset diabetes. Is that a way in if all of a sudden you develop diabetes? One every few hundred people will with new onset diabetes will have a pancreatic cancer, we think. So it's not an easy one to answer. Unexplained, nausea and jaundice or certain lab abnormalities. Again, it's a conversation with your doctor because it's not that easy to dissect that answer on your own. Unexplained weight loss, warning symptoms should merit a CT scan.
And will CT scans definitively pick up the diagnosis, or because you mentioned that's not all scans and MRIs are alike. So let's say you end up getting it's negative, but you still have these symptoms.
Yeah, so hopefully it is another explanation. I mean, the pancreas scan, if you're looking for pancreatic cancer, the concern is often people will have a general abdominal scan, or they'll be referred for an endoscopy, or they'll be treated for, non-specific GI symptoms with a medication. And it's tricky to figure out because most of the time it's not going to be pancreas cancer. But yes, if you are suspecting pancreas cancer, you definitely need a pancreatic protocol CT to optimally see. And sometimes, occasionally, you won't be able to pick up even when there's symptoms. Usually when there's symptoms, though, the cancer isn't tiny and isn't that hard to find with an appropriate scan. But, that's again, the doctors, we will do the follow-up imaging with, complementary sometimes, a second exam, an endoscopic exam, an MRI scan can be necessary. It can occasionally be hard to diagnose.
Are these imagings available do you think in most places in the United States? Or is it really just sort of in the bigger cities where the bigger hospitals are, like Johns Hopkins?
Yeah, the scans vary in quality, yes, and access to certainly endoscopic ultrasound is the most specialized and the least available. MRI scans, of course, in certain remote areas, it can be a challenge to get these scans or have the type of MRI scan with that sufficient quality. So that's we're still figuring out how to optimize rural healthcare. But a good CT scan is available in many, certain emergency settings. They're very, like a 10-second scan. So that would be usually not the major thing. If you're having symptoms, a CT scan would often be sufficient quality, but not always. Not always.
It's a good start. Thank you. Our next question, so this kind of leads into our next question from Sarah, because she lives in North Carolina. And she has a 43-year-old son who has the BRCA1 mutation. And he was told to get screening at age 50. Do you agree? Do you agree with that?
Yeah, so what we normally do is take into account the pancreatic cancers in the family. If there's early onset pancreatic cancer, then we would start at a younger age. The various genes, the BRCA2s, ATM, CDKN2A or P16, BRCA1 is on the lower end of pancreatic cancer risk, thankfully, compared to BRCA2 and some of these other ones. And so 50, again, reflecting the general incidence of relatively modest incidence in pancreatic cancer. Of course, other cancers are possible, prostate and even male breast cancer. These are it's good to see somebody who has an overview of all the cancer risks related to BRCA1, getting a colonoscopy done, et cetera. But 50 is a reasonable age unless there's young onset pancreatic cancer in the family, in which case we would start earlier, maybe 45 usually.
Great. Thank you very much. Leah would like to know, would people who have family history of BRCA1 or BRCA2 breast cancer, but not pancreatic cancer, be candidates to be screened?
Yeah, this is also a very good question. This reflects a long history of trying to optimize management. Way back in the 90s and early 2000s, us pancreatic folks would be, why aren't the BRCA people who take care of people with breast cancer talking about pancreatic cancer? And because there's a lot of families where that's, they would go to see experts for their breast cancer history, and their families never had any pancreatic cancer. And of course, maybe the incidence has changed, and maybe the management of breast cancer, much more cancer prevention in this group. So we started with a philosophy 25 years ago of, do no harm, identify the people at highest risk. And so the family history of pancreatic cancer was very important. With our results showing, some promise, again, bearing in mind, most people who go undertake surveillance will be okay. We've now felt more that, look, we know how to do this better, and we shouldn't be restricting to especially mutation carriers who are at risk of a variety of cancers. Some of the scans will pick up the rare cancers in other organs nearby that BRCA1 people are also prone to, and their bile ducts are nearby. So we do recommend surveillance, even if there's no, a kind of a pancreas surveillance, even if there's no family history of pancreatic cancer in the BRCA carriers. Now, that's not based on our long history of experience, because we didn't always do that, but we do think it's reasonable, and we expect the data will show that over time.
So do you find, so that using that number 50, apparently what this, what Sarah, was told about her son, that once she hits 50. So is that sort of the kind of the age that was chosen? Do they have facts? I guess they have data on that.
Well, we do have a lot of data in general about how pancreatic cancer occurs in the general population, how it occurs in families, at what ages it's diagnosed, and we try to anticipate the average diagnosis by some years. And in fact, we have shifted down a few years in general. We used to say 55 and 50, 55 for mutation for family history, and 50 for mutation carriers in general. Some of the rarer mutations are actually earlier. And so we have tended to shift it down to, more 50 and 45 for generally for mutation carriers, 50 for family history, but we still take into account the other factors. So there, if somebody, happened to smoke or, there are other reasons to bring it earlier, we will sometimes do that. Certainly if they have a young onset pancreatic cancer. So that's a tough question. Because the incidence is low. Most people are going to be fine. Much lower, even if you have these, family history risks than in general than when you're older. So maybe at some point we'll be maybe doing a different test or a less often test when you're very young. But it's still a challenging question to really answer well, because it's not like we're very good at really outstanding at predicting these things, right? We're just using a lot of clinical judgment.
Well, you're getting better. We're going in the right direction.
Yes, I guess.
Okay. So the next question from Desiree: what's the difference between germline mutations and somatic or acquired mutations?
Yeah, so germline is meant, even though we take a blood test or a saliva test, it's meant to be that you're looking at all the cells in your body and what you inherited and carried, from birth, from you were a little embryo kind of thing. Acquired or somatic is in the context, generally in the context of a cancer, but you could acquire mutations in your skin as you get older, right? As from UV light. So those are, but you acquire them naturally just through the course of age and other factors, and that's what will sometimes be studying in somebody, let's say, who has a cancer. They get a tumor mutation profile. Those are acquired or somatic. Generally, we can sometimes see the inherited mutation in that sample as well, but a kind of a blood test or saliva sample is for germline. A kind of a tumor sample is for somatic.
Great, thank you. Leah wants to know, what is the relationship of diabetes and pancreatic cancer? And two-part, and should all late-stage diabetics be screened for pancreatic cancer?
That's also a good question. There's a number of reasons why people with diabetes can get pancreatic cancer. Thankfully, most of them don't. They have much more to worry about their general metabolic health and, keeping their sugars down for preventing a variety of different complications. So, a slightly increased risk, 1.5 times or so if you're a typical diabetic who compared to the general population. So thankfully, overall, not too much higher risk. So we don't generally say, once you reach a certain age with diabetes, you should get screened. There is this one other factor, which is, of course, if you have a pancreatic cancer and you never had any diabetes, and now the pancreas is getting dysfunction because of an emerging cancer, and you don't have any other sign of trouble, would the new onset of diabetes, last year your sugar was fine, and now you have diabetes, should that merit a scan? And sometimes when that happens, you may then, well, maybe there's some subtle other findings, I've bit vague symptoms, or lost a few pounds, or so we certainly have as a clinical judgment that should be considered in that window of, I've just been diagnosed newly with diabetes. And in that period of the year around that period can certainly be a timely time to get a pancreas scan. that again is judgment, and there have been some studies on this. But thankfully, when you're in that situation, most of the time, probably, maybe 1 in every 200 people, it could be for pancreatic cancer. Most of the time, it's just because as you get older, and for a variety of reasons, people get diabetes, and it's common in the population for all the general metabolic reasons, the excess weight and all those kinds of factors. So we don't recommend it routinely. There have been some studies looking at new onset diabetes, and should we be, doing blood tests or other scans for looking for pancreatic cancer, and that's sort of work in progress. But certainly, if you have new onset diabetes, it's a question: should you get a scan like once off? Is something that may end up being the case, but it's not a routine for everyone.
Sure, great, thank you very much. So Deborah would like to know: is bile duct cancer related to pancreatic cancer?
That's a good question. It's certainly anatomically very close, and they'll present often in similar ways, right? You would have the kind of jaundice or pain in a similar location. You can even have the cancer kind of growing into the pancreas if it's from the bile duct, and the bile duct into the pancreas, because the bile duct sort of goes through the pancreas before it exits the duodenum, and the genetic factors that we see, some of them overlap. We think some of them are different. So it is a different organ, and has different risks. So in many ways, but we see a similar. If some of these family histories, we don't tend to see too much of pancreas and bile duct overlapping. Not too much. We do see some of the rarely BRCA. It's not a common cancer, thankfully, but they could be at increased risk for those kinds of cancers if let's say you're a BRCA mutation carrier. So it's sort of another reason to scan your pancreas, because you get the bile duct as well.
Thank you very much. We have a couple more minutes, so there's another question from Janet. She says the NCCN still links recommendations for pancreatic cancer screening to family history, even for those with BRCA2, etc. What other guidelines do you suggest we follow?
Yeah, and I'm part of the NCCN for the genetics. So this again is there's a variation in opinion about this because of the do you anticipate, or do you and using the judgment before the evidence is, because in this context it's very hard to get the evidence accumulated. So for example, a decade ago we identified another gene, ATM, as a cancer susceptibility gene at Hopkins. Some of my colleagues led that, and I was part of that. And we had to decide, well, we don't know yet how significant that risk is lifetime. Should we be including people? And we decided that we should. We anticipated it would be worthwhile. And so that is a judgment. I think my view is that we don't yet know well enough. We think the risk is certainly lower if you don't have a family history of pancreatic cancer. But the idea that now that we understand how to do surveillance, many families are small. They die of other things, excluding people because they lack a family history is problematic. It's probably something you can make a case for if you're from a large family. You have 10 siblings and loads of aunts and uncles, and your cancer history is well understood, and there's not a speck of pancreatic cancer around. Well, life is short. Maybe you don't need to get pancreatic surveillance. But often, families are small, and excluding them, I think, is problematic. Especially as more cancer prevention occurs and people survive longer with BRCA mutations, we have to consider that over time they're going to be at risk of other things. So it's a judgment, and the societies have leaned in different directions regarding that, such as NCCN going one way, our CAPS going another way, and one or two of the others have agreed with the idea. But that just tells you that the jury isn't fully there, and the evidence has not yet been accumulated.
Right. Great. Well, thank you so much. Looks like we're getting very close to the 8 o'clock hour. I would really love to thank Dr. Goggins, for speaking with us tonight. Thank you so much for your time and information. It was very valuable. Dr. Goggins has graciously agreed to respond to any unanswered questions that were asked this evening. So in a couple of weeks, you'll receive an email outlining the outstanding questions and answers. In the coming weeks, a video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/a-woman's-journey, under videos on demand. And if you have enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/a-woman's-journey, for more information about upcoming webinars, our Health Insights That Matter podcast series, sign up for our monthly emails, and register for our in-person events. To learn more and to register online, again, please visit the A Women's Journey website at hopkinsmedicine.org/a-woman's-journey. Thank you, good night, and stay well.